Good morning, everyone. It's my pleasure to welcome everyone who's here in the auditorium, as well as joining us virtually for the 46th Annual Kenny Drash Memorial Lecture. This lecture series is a source of great pride to us pediatric endocrinologists and was established in honor of two of the pioneers of pediatric endocrinology all over the world, but also who had their career here. Dr. Kenny, the first part of the Kenny Drash name, was Director of Pediatric Endocrinology here at UPMC from 1962 to 1975. He established both the clinical and research wings of Children's Hospital of Pittsburgh of UPMC. He was the first to use cortisol secretion studies to establish normal adrenal functions in children and adolescents. He is regarded as a role model in terms of integrating the clinical responsibilities, the mandate to teach at all levels, and continued inquiry into the mysteries of endocrinology, the Oslerian triple threat, which is getting rarer and rarer these days. Dr. Drash followed Dr. Kenny as Director of Pediatric Endocrinology in 1975. He served as director from 1975 to 1990. Dr. Drash led the field of glucose metabolism. He led the field in confirming that insulin deficiency is what distinguishes type 1 from type 2 diabetes. He was the first to use immunoassay for insulin measurements in pediatrics, first to show that diazoxide can be used as a medication to decrease insulin secretion in the treatment of hyperinsulinism, and more conceptually that changed the whole diabetes care in the world is to introduce the concept of a diabetes educator and make diabetes a team sport or team-based care. And one of the first diabetes educators are from CHP, and one of them is still continuing to serve as Linda Seminario as Director of Diabetes in the Adult Endocrinology. He was popularly called Mr. Pediatric Diabetes and had the rare honor of being president of three major societies, the Pediatric Endocrine Society, American Diabetes Association, as well as International Society for Pediatric and Adolescent Diabetes. So the lecture series is established in this honor. And I want to show a clip of some words from a letter that he wrote to his daughter, Allison, Dr. Drash. There's nothing more important than to be consumed by a sense of dedication and responsibility to a calling that takes one out of oneself and into the service of the others. And he says, I could get by doing far less than I do, but I love my work and the wonderful opportunities it has provided me. I'm excited every day when I get up and start to work because I know I will be presented with new chances to advance knowledge and help others. He trained many leaders in the field currently. Many of us are in the division with us even today, and who carry this principle every day to work today, as I can say. So every year we have the honor of inviting somebody in the pediatric endocrinology field who epitomizes not only the passion and dedication to serving pediatric endocrinology, children with pediatric endocrinology disorders, but has also helped advance the field. In the true spirit of lecture series today, we are very honored to invite Dr. Tom Carpenter to deliver the 46th annual Kenny Drash lecture today. He is professor of pediatrics in Division of Pediatric Endocrinology. He's also professor of orthopedics and rehabilitation, and he's a clinical professor of nursing, and he directs the Yale Center for X-linked Hypophosphatemia, and he is the medical director of the hospital research unit. Dr. Carpenter did his undergraduate degree in Virginia, then went on to do his medical school at University of Alabama and his intern year and residency at University of Alabama. He was a fellow at Harvard Medical School at Children's Hospital Boston and went on to join the faculty as instructor before he was recruited to Yale as assistant professor of pediatrics. He has remained there through many decades, risen through the ranks, and as I showed you, he's professor of pediatrics, orthopedics, and nursing currently. He has maintained a career-long interest in metabolic bone diseases in children, some of which he'll share with us today. His research and clinical interests focus on the pathophysiology and development of novel therapeutic options for X-linked hypophosphatemia, the most common inherited form of rickets. He also has a major interest in vitamin D metabolism and pediatric metabolic bone disorders. He's published more than 200 articles and reviews and chapters, a record number. I counted 67 textbook chapters, all on metabolic bone diseases in children. He's currently an associate editor of Journal of Bone and Mineral Research. He has received many honors in his career. I'll just mention a few. He was recently awarded the Distinguished Clinical Career Award at Yale School of Medicine. He was the George Lowry lecturer at University of Michigan. He won the Pfizer International Award from Endocrine Society for excellence in published clinical research in JCEM. He was also the 12th annual Judd Van Wyck Lecturer at UNC. He is currently the president of our Pediatric Endocrine Society, and it's my honor to invite him to deliver the 46th annual Kenny Drash Lecture. The title of his talk is Mineral Homeostasis in the Bone, the Interplay of Calcium, Phosphate, and Vitamin D.
Thank you very much for that kind introduction. Just trying to get this into presentation mode and making sure that it is up. Is it working?
Yes, it's working.
Great. I again want to thank you for that very kind introduction. It's indeed an honor to be.
Oh, excuse me, Doc. I don't mean to interrupt. It's not that you need to share through your Zoom call. We're not seeing your slides through the presentation.
Okay, just a minute. Let me see why that came off. I thought it had come on. It says I'm screen sharing now. Is that working?
That is working. You just need to put it in full screen and you'll be fine.
There you
go. That is better. Thank you so much.
All right. So once again, this is really an honor to be invited to give the Kenny Drash lecture. I didn't know Dr. Kenny, but in my time through making various travels and the rounds around to various places, I met Dr. Drash, and although it was brief, I think it was on a Friday when there was a big diabetes clinic, or it might have even been on a Saturday, because I think he had it structured where people did diabetes clinic on Saturdays just before the Pittsburgh football games or something like that. And I remembered that, but just in recently looking up a little background on him, I realized we had a deeper connection, and that had to do with Dr. Drash's roots in Birmingham, Alabama, where I went to medical school and did my internship and residency. He was a star football player for the Ramsey High School Rams, which was just a couple of blocks from where I lived during those 7 years in Birmingham. And I used to walk around there and actually run on their track, even though it was becoming defunct as a high school at that time. For many years, he was a legend at that school. And in fact, other very famous football players referred to how good he was in high school because rival schools there had to play him. And he was apparently a ferocious football player. All relevant to people in Alabama, as that is a major activity there. But without further ado, I would like to first list my disclosures. And secondly, thank you again for the opportunity to show you where I've spent most of my life living in the pediatric endocrine world, and that's in the bones. And I'll start by registering with you the sense I had about the bones when I first entered my fellowship, and that was that it was a fairly dull and unexciting tissue, that it was pretty much this brick that your muscles clung onto, and it didn't really have too much activity going on. It was just this very inorganic structural material. And, you know, by weight, that is true, but there's a lot going on in bone, and its composition is really complex. And it became interesting to me during my fellowship to try to understand how the living pieces of bone regulated materials that would then become structural. And that breakdown sort of looks like this, that by weight, only about 5% of the bone is cellular, but it's where a lot of the activity goes on. These are mostly osteoblasts, osteoclasts, and osteocytes, which we'll talk about as through the talk. But there's also important players in the hematopoietic cells and stromal cells that support some of the activities of the true bone cells. About 25% of bone is organic matrix, predominantly collagen, but there are about 50 other or now more proteins that play important roles in helping collagen assemble and giving creating a matrix in which mineral can be integrated and organized. And then, as we've said, the bulk of the weight of the bone is the inorganic brick-like material, predominantly hydroxyapatite, which requires calcium and phosphate in order to be appropriately made in its crystal function. This cartoon sort of shows the cycle of what goes on as bone turns over in your body. These big red cells here are representing osteoclasts. And if we just look at this cycle, you can see that they come into an area that has been around a while and may need to be remodeled, perhaps where there's been a little small microfracture or something. And they're attracted to this area. They become activated in in this particular part of the cycle, where they begin to dig out the old bone through a process that's actually very complex and interesting. And as they create the resorbed space, they begin to die off and leave and move to some other site. And in that matrix, as we progress along the cycle, pre-osteoblasts are called in and begin to set up shop. And as that progresses, they become plump and they start to secrete new matrix. And that new matrix then has to mineralize. Now, some of these osteoblasts are further differentiated to what's called an osteocyte. And here we see the osteocyte becoming embedded in the matrix, and then it becomes mineralized, having restored and repaired the area that the osteoclast had started to resorb. Nevertheless, this osteocyte stays in the bone, and although we've thought it was a less important, rather meaningless cell that was perhaps represented a dead or entombed osteoblast, it turns out that this cell becomes very important in the regulation of bone cell activities. And mineralization then sets in. One can begin the whole cycle again. We'll look at it in a different way here over time. This slide is structured to point out that the resorption phase is relatively fast compared to the new formation phase. Here, if we're sort of progressing from left to right, the osteoclasts in purple come in to resorb. This resorption phase is roughly a 3-week phase at a site of bone. And then as the lacuna is then attracting the pre-osteoblasts and the osteoblasts. They then lay down the new collagen and it becomes mineralized. That full process of the recruitment of the blasts, the synthesis of the matrix, and the mineralization with the osteocytes becoming part of that network, that whole process is about 3 months. So catabolism is fast, anabolism is slow, and that sort of fits with a lot of the other things we know about biology. And just to show you in real life, this is the same sort of thing here. If we just follow this biopsy, you can see that the mineralized bone is shown in green, and this pale pink area with the multinucleated cell is an osteoclast. It's a series of these osteoclasts. You can see the scalloped out edges where it's been resorbing. And if we follow this back, you can see the lacunae that have been generated by this parade of osteoclasts. And back over here on the right-hand side of the slide, this line of osteoblasts has been laying down new osteoid, the unmineralized collagenous matrix that stains here in a very pale pink. And this then mineralizes. So I think the cartoon is very representative of what goes on in reality. This is just showing you the same thing in a animal experiment we did. You can see how plump these osteoblasts get along the surface of the bone. The staining here shows the unmineralized matrix in the very light blue. In the same slide on another trabecula, you see the osteoclast beginning to resorb out the bone. So this is the process of bone turnover, which is going on in both children and adults, but becomes a major factor of regulation of bone in adults where growth has ceased. So what about growth? Well, the primary formation of the long bones occurs by a process called endochondral ossification. And the cartilage template that is evident embryologically begins to differentiate into specialized chondrocytes that can mineralize. And as these areas mineralize, the chondrocytes expand into the long bone to the ends, creating growth plates. And although this cartoon shows this as a symmetric phenomenon, in reality, the bulk of the growth is not symmetric. Say in the femur, it's mostly the distal femur that has the more extensive growth rather than the proximal femur. But these growth plates are remnants of the original cartilage that started to form in the cartilage templates, and the cartilage and chondrocyte array there becomes very important in our understanding of how long bone growth occurs. So what about the bone cells? We'll start with the osteoblast, and it is really obviously a critical cell and the source of the collagen that is the bulk of the matrix that's required to make the mineral. In this osteoblast, we see these two green chains of procollagen being synthesized. They represent the alpha-1 subunits, and the purple being the alpha-2 subunits. And these chains, as they come off the ribosomes, they, in a ratio of 2 alpha-1s to 1 alpha-2 chain, recognize each other in the C terminus of the molecule. And free energy, once that recognition has occurred, favors them winding up back to the N terminus in a triple helix, which is the characteristic compact structural molecule that will serve as the basis of the collagen that's laid down in bone. There are a number of other important proteins in this process that help to cross. These little balloons represent enzymes that help cross-link the amino acids to give a tighter bond between the chains and stabilize the triple helix. There are chaperone proteins to help this get through the Golgi. Eventually, this procollagen triple helix is secreted out into the extracellular space, and specific enzymes clip off the ends of the pro-collagen molecule, leaving this very tight, compact collagen bundle that organizes itself in arrays to give you the, the groundwork for what you can mineralize. Now, this is kind of important clinically because it's this pro-collagen fragment that is measured as a marker of bone formation. Many of you may, in your clinics, order, the typical one we order is the P1NP, or the N-terminal pro-collagen fragment. And it's part of, the antibody sees part of this complex here that's cleaved off. And one can see that collagen production is going to be marked by how much of this gets cleaved off. So the more collagen you make, the more active the osteoblast is, the more anabolic the process is, the greater the concentration of this fragment is going to be in your circulation. And that's why we use P1NP as a marker of bone formation. It's a complex cell with all kinds of other pieces to this. You have to have a good cytoskeleton for all of this machinery to work okay. And you can see how they've drawn in microtubules and actin to make that. And this is a mesenchymal cell of mesenchymal origin. So we'll move on to the osteoclast, which is a very different cell, but also very specialized and very interesting in its own right. Here's a EM of an osteoclast showing its size, and also the very almost spiculated surface that it has. Here's an attachment, an electron micrograph of an attachment of an osteoclast to bone, the bone being the dark black area in the top part of this insert. But you can see this being the cytosol of the osteoclast. You can see this very redundant border here, which is called a ruffled border, is part of this interaction. And this is an extremely complex region. It expands the surface area of the cell tremendously in the pocket where the bone resorption is going to occur. And that allows for a very heavy concentration and secretion of both enzymes and acid to help with bone resorption. We can sort of look at it this way too. Here is the osteoclast finding its way to the bone surface. It seals down at these clear zones over the area it wants to resorb. This is a, cartoonish representation of that ruffled border, but it's through this ruffled border in the extreme surface area that it allows that hydrogen ions are pumped into their enzymes such as cathepsin K, matrix metalloproteases, other lysosomal enzymes, acid phosphatase. All of these are pushed into this pocket in the bone resorbing space. And it's the combination of the acidic environment and the enzyme activity that both releases calcium from the matrix and breaks down the collagen. Now, that third cell, the osteocyte, here's a picture of cortical bone with these osteocytes all lined up in this array. It turns out that in a given unit of bone, there's generally more osteocytes than there are osteoblasts and osteoclasts. And they're very orderly arranged, and they talk to one another. There are channels that run between these things, and they're a very interesting communicating cell of the skeleton. Here's an electron micrograph of an osteocytic lacunae and all the canaliculi coming off of that cell that connect it to others. And here's the bigger picture where you can see an osteocyte talking to another one, to another one, to another one. And this coordinates the activity of bone so that one part of the bone knows what the other is doing. In fact, you can see on the bottom here that a lot of these canaliculi go to the surface of bone, and it's here where they're thought to communicate with the surface cells, the osteoclasts and the osteoblasts. The extension of these cells is in fluid dynamics all the time, so that there are extensions of these cells that are kind of moving, and they'll, under certain activities, come out to the surface, retract in, and so it's a very dynamic system. These things change with age. You can see here in this Herversian picture of a young, in this light microscopy section of a young Herversian canal from a young animal. You can see the osteocytes all lined up in their orderly arrays and the connections. Here's a close-up of that osteocyte. And when you get to be older, you can see that they begin to be sparse and the connections become sparse. So you don't have the quite the communication within your bone at an older age that you do in a younger. And you can see this here also with a special staining, the lower density of those connections. So this is a slide that sort of builds that information in, and it, I think, is important because it informs us as to where some of the new targets for treating bone diseases are coming from. If we just take this little panel here and we look at what are some of the things that regulate bone resorption, this receptor here called RANK, analogous to functions with immune cells, stimulates through the NF-kappa B pathway activity of these cells, and in the case of the osteoclast, bone resorption. Now, this is regulated by a protein that comes from the osteoblast called RANK ligand, and it's represented by this little yellow circle. And so when the yellow circle sees the RANK ligand sees the RANK, it turns on osteoclast activity in bone resorption. This also is a mechanism by which the coupling of osteoblastic activity is kept in parallel with the activity of the osteoclast. Now, there's kind of an interesting check on this system by another protein called OPG, or osteoprotegrin, which is a soluble protein and shown here by these orange little cups, and they compete with RANK for the avidity of binding to RANK ligand. So if you want to turn down resorption, the osteoblast makes osteoprotegrin to capture the RANK ligand so it cannot stimulate the osteoclast. So knowing this biology, investigators made an antibody to RANK ligand, and that has become a major anti-resorptive drug, which we use in some pediatric situations, more commonly in adults, which is called denosumab. And that biology informed the development of that particular medication. Now, over on the formation side, one of the driving pathways in this is the Wnt signaling pathway. And it turns out that osteocytes make a number of proteins that have an effect on the Wnt signaling pathway that generates the activity of, generates osteoblastic activity. And the one I'll point out here is shown by the blue triangle called sclerostin. And sclerostin is a product of the osteocyte, probably delivered by those canaliculi to the surface of the bone, affecting those osteoblasts. And sclerostin inhibits bone formation. So the higher the sclerostin level by the osteocyte, the more you dampen the anabolic limb of bone activity. Now, it turns out that sclerostin is also a target and has become, if you can inhibit that inhibition, you will then generate anabolic activity. That is, you inhibit the inhibition of bone formation, allowing for specifically very positive effects on anabolism. And the way one can do that is with an inhibitory antibody to sclerostin. And this has seen recent pharmaceutical development with the drug that has now been approved for treatment in adult osteoporosis, romosozumab, the first really major non-PTH level anabolic agent to treat osteoporosis, and it's been very successful. A very similar antibody to sclerostin called sertrucimab is currently in clinical trials for the treatment of osteogenesis imperfecta. So the idea that an anabolic agent could help disorders in childhood, such as osteogenesis imperfecta, and perhaps improve upon the effects we see with bisphosphonates is now out there. So then we get to the mineral phase itself, and this requires providing adequate substrate. And in the course of making hydroxyapatite, one can go back to your chemistry and realize that you need a certain amount of concentration of ambient calcium and ambient phosphate to push that reaction to the formation of hydroxyapatite. If you have a diminished supply of calcium, you actually slow that reaction and you don't make as much, you don't mineralize as much. You can also reduce the amount of phosphorus and also impact the equation in the same way. Now, in addition to the nutritional supply of those minerals, there's local regulation of mineralization, and that's demonstrated in this pathway. This is a recent area that's been targeted to pharmaceutical intervention as well, but the pathway relies here upon the appropriate, as we've just said, appropriate ambient concentrations of calcium and phosphate to make hydroxyapatite. The calcium predominantly comes from nutritional supplies. However, the phosphate is regulated, is generally ample in nutrients, but is regulated locally by an interesting enzyme network, as well as by renal retention of phosphate, such as with the phosphate wasting diseases that we'll talk about shortly. But one can interrupt the production of hydroxyapatite even in the face of adequate calcium and adequate nutritional phosphorus. If you don't have this enzyme here, tissue nonspecific alkaline phosphatase. And the reason this happens is because some of the local phosphate at the mineralizing site is due to the action of alkaline phosphatase cleaving the mineralization inhibitor pyrophosphate, two phosphates joined together, to produce some of the local phosphate required to allow for the mineral formation of hydroxyapatite. So without TNAP, without alkaline phosphatase, one accumulates pyrophosphate, which has a specific effect on inhibiting mineralization, as well as limiting the supply of phosphorus, which would be pro-mineralization. And the net effect is not to mineralize. And that, of course, is the disorder hypophosphatasia, which is extremely rare, but very informative in terms of how local phosphate regulation works. Now, on the other side of the coin are patients that have a defect in the enzyme ENPP1, which is the phosphatase that is responsible for making pyrophosphate by cleaving ATP into AMP and the biphosphate moiety pyrophosphate. In this condition, if you lose ENPP1, you cannot make the mineralization inhibitor. And this has devastating consequences in the vasculature where you don't want to mineralize. When you have a deficiency of pyrophosphate, you allow for the vascular cells to mineralize, and that generates severe intravascular calcification in a rare disorder known as generalized arterial calcification of infancy, with about a 50 to 60% mortality rate in the first 6 to 7 months of life. So that is a disorder to know about that is a direct result of an interruption in this pathway. There are other channels that may play roles in this that allow for the transport of pyrophosphate out of the cell, that may allow for ATP transport, that can influence these as well, but they're not quite as overtly demonstrable of these diseases as the ENPP1 deficiency or the TNAP deficiency. So this leads me to the area that I've spent much of my clinical area of interest in, and that's looking at rickets. You see this and you kind of wonder, how can this be going on in an industrialized world where we would think most people would be well nourished? Well, rickets is a disorder of the skeleton. It's characterized specifically by growth plate disorganization. It results in the proliferation of unorganized cartilage, and so it interrupts growth. And there's a coincident bone problem that occurs in addition to the growth plate lesion, and that is osteomalacia. And if you have the pathophysiology of rickets as an adult, you no longer have a growth plate, but you can have pretty rip-roaring osteomalacia. Now, rickets has been around for a long, long time. Here's an old report from the 1600s talking about the mortality causes of death in London in the 1600s. And you can see there are all kinds of things here, gangrene, smallpox at very high numbers. But rickets accounted for 14 deaths in 1634 in London, and even piles accounted for 1 death. So this was quite a fully accounted for group, but we've known about rickets for a long, long time. And what we see when we see rickets today are the end results of this expansion of the growth plate, such as the physical finding of a swollen wrist is shown here, or the ricketic rosary, which is essentially the swelling of the growth plate at the end of the rib. And the osteomalacia plus the aberrant growth over time, when the child is weight-bearing, results in either a bow or a knock-knee deformity. Sometimes you can see a bow deformity on one side and a knock-knee deformity on the other, a so-called windswept deformity. And if you take an X-ray of those areas, you see the classic radiographic features of rickets, in which the very nice border of the metaphysis with the growth plate, which is usually very sharply defined, becomes ill-defined and is what we call frayed. The width of the growth plate flares out. Sometimes it has a bowl shape to it. It's said to be cupped. And if you look at what that means histologically, we'll look at this cartoon and recognize that if we take a section of bone from a long bone, and these are done in animals, but the same idea applies, where you have the secondary ossification center mineralized above and the secondary spongiosa of the metaphysis below. You can see over here in the left panel of the histology, the mineralized bone staining in green nicely in the epiphysis in the upper part of that slide. This is a normal growth plate. And you can see in the growth plate, the red, pink staining collagen. You can see within the growth plate, these columnar arrays of chondrocytes, nicely ordered, resting zone at the top, proliferating zone in the center, and these larger chondrocytes at the bottom, hypertrophic chondrocytes, which have the capacity to mineralize the new cartilage. And it's that edge of constant mineralization reiterating itself over time that allows for the growth of the long bone from the metaphysis upward. Now, if you have rickets, we go over to panel C on the far right, and you can see a little, they've captured a little bit of the epiphysis in this slide. So you see a little bit of the green mineral here, but you see the loss of the nice columnar arrays. You see an expansion of the chondrocyte layer particularly, and you see lack of mineralization of the secondary spongiosa in the metaphysis. So this disorganized growth plate no longer is set up to appropriately grow in a linear fashion. It expands in a lateral fashion. It's responsible for the radiographic findings you see in rickets, which accompany those physical findings that you see. Here's another picture in a rat that was made vitamin D deficient. This is oriented in a horizontal manner where you see the epiphysis here, the very nice growth plate centered here with the columnar arrays of chondrocytes, and the nicely mineralizing metaphysis here. And after a couple of weeks of vitamin D deficiency, no calcium getting to the skeleton, you see this markedly disrupted growth plate with no organization of the chondrocytes expanding in all directions. So that is a classic severe rickets picture. So what about osteomalacia? We're now talking about the bone, not the growth plate. And as we've seen from our earlier slides, one generally has this, if you take a piece of trabecular bone, you have mineralized bone. Some of it's new bone, perhaps recently made and mineralized by the remodeling cycle we discussed earlier, and a very thin layer of unmineralized osteoid that has lining and telling you that the osteoblasts have recently been there. On a biopsy, you see something like this. You see the mineralized bone in green, and you see some of the surface having that osteoid where recent osteoblast activity has been. And if you look at what happens in osteomalacia, you don't have the appropriate mineral. You cannot mineralize the newly synthesized matrix. So the volume of all the bone there is similar to what's in normal bone, but the unmineralized portion is extremely, the extreme to the extreme in terms of excess. And the biopsy thus looks like this, where the green mineralized bone is present, but the excess unmineralized osteoid is all over the place. And we characterize osteomalacia on biopsy by quantitating the area or the volume of the red staining unmineralized osteoid. This kind of bone is subject in adults to pseudofractures, as you see here. So we, for convenience, classify rickets into those that seem to be unable to mineralize because of the lack of calcium availability to the skeleton, and those that are due to the impaired availability of phosphate to the skeleton. Calcium is regulated primarily by the intake. One runs into clinically a lot of calcium deficient diets, and it's dependent, particularly in the right after the neonatal period, on adequate amounts of vitamin D. And we know that happens because of the vitamin D receptor seeing the activated metabolite of vitamin D enhancing calcium absorption. Calcium also moves in and out of the skeleton under the influence of PTH and activated vitamin D, and it is to some extent regulated by parathyroid hormone at the level of the kidney. That is, PTH tends to reclaim calcium, not to the same magnitude of control that PTH does for phosphorus, but that certainly is a well-known phenomenon. So our calciopenic rickets, as we've said, tends to come from vitamin D or calcium deprivation. You can poorly absorb calcium. You can have defects that we'll briefly talk about in terms of the synthesis of vitamin D or the active metabolite. And you can have mutations in the vitamin D receptor that lead to resistance to the active metabolite of vitamin D. Here is the classic vitamin D pathway where we know the steroid ring breaks upon exposure to sunlight or you ingest it. Vitamin D is rapidly isomerized from the broken steroid ring of pre-vitamin D. It's then 25 hydroxylated out on the side chain, and it's this metabolite, 25-hydroxy-D, that we measure to ascertain vitamin D deficiency. It's the most abundant circulating metabolite of vitamin D, but it's not the active metabolite. The active metabolite requires another hydroxylation on the A ring of the steroid nucleus. You can see it added on right here. and that's activated vitamin D. It circulates as at 100 to 1,000-fold lesser concentration than 25D, and it's not a good marker of vitamin D deficiency. The catabolic pathway does a second side chain hydroxylation at the 24 position out here, and this begins the breakdown of vitamin D. Now, we get this calciopenic rickets either by not ingesting enough calcium or vitamin D, or not getting enough sunlight. You reduce your vitamin D stores, you ultimately make less 125, perhaps, which can be transient, but this leads to poor calcium absorption. You drop your ionized calcium, but you correct it by increasing parathyroid hormone, but that then makes your phosphorus drop, and the phosphorus drop further, in addition to the low calcium, inhibits the bone mineralization we've been talking about earlier. You can get confounded as the PTH goes up because it will tend to try to make, in a compensatory fashion, more 125D, and you can get into these situations where your calcium absorption is knocked down, but your 125D is bumping up in the higher levels, and that's a paradox. It's not fully explained, but we certainly see it a lot clinically. This is a case history of a 9-month-old boy who came to our clinic some years ago. He had poor growth. He was breastfed. His parents were of normal height. He was very short. He didn't have craniotabes or rachitic rosary, but he did have the widened wrists. He wasn't walking yet, so he wasn't bowed, but his radiographs had sort of classic findings of rickets. And his biochemical profile showed a borderline low serum calcium, quite a low serum phosphorus, but pretty high alkaline phosphatase, and a very high PTH level, about 10 times upper limit normal in the assay we were using at that time. His vitamin D level wasn't out of our range of the 20 to 50 range that we use. And his 125 level was normal for age, not particularly high given the PTH level. But we recognized he wasn't getting any, he had been weaned, he wasn't getting any dietary calcium. And we actually treated this boy with calcium alone. And you can see in 2 weeks, his phosphorus coming up, his alk phos coming down, his PTH coming down, not much of a difference in his vitamin D level. By 7 weeks, still further correction of the PTH. By 16 weeks, everything really nicely normalized, and his x-rays by that time had fully normalized. So the point of this case is to tell you that calcium is part of the equation. We like to treat most of these kids that show up with a combination of vitamin D and calcium. They probably have nutritional deficits of both. And just to go back to our earlier paradigm, if you have normal vitamin D, you can sort of short-circuit this pathophysiology by, if you have very low calcium intake, you're going to eventually wind up with the same problems that result in the low bone mineralization. In reality, I think that there's probably this combination of things that if your calcium intake is very, very high, you might be able to get by with a slightly lower vitamin D level. If your vitamin D level is higher, you might be able to compromise your calcium intake slightly. So it's perhaps not that you have a pure vitamin D deficiency or a pure calcium deficiency, but you have some movement somewhere in between. Now, one interesting phenomenon that's evident from earlier animal studies is we know that you become calcium deficient if your vitamin D is low for a long enough period of time because you can't absorb calcium, but you also increase vitamin D turnover if you're on a low calcium diet. And this is, again, why these two nutrients are related. This is an old rat study in which animals were put on either normal calcium diet, shown here in 0.64%, or a low calcium diet. And they were sampled at a point in time where their calcium levels were still equivalent. Yet their 25Ds were beginning to diverge, with the low calcium ones showing a lower level. The 125Ds had already come up in the low calcium diet group, but a half-life experiment was done where radioactive 25 vitamin D was injected and how long it persisted in the animal was clearly different, about 50% more rapid turnover of vitamin D, of 25-hydroxy D, if you were in a low calcium diet. So that is also playing a role. That's kind of a spiral. You get to lower vitamin D, then you're going to absorb less calcium. You have less calcium, you're going to turn over the vitamin D faster. So with respect to some of the recently identified metabolic defects, we know of defects in the conversion of 25 to 125, so-called 1-alpha hydroxylase deficiency. We have a couple of patients with that. They respond pretty well to calcitriol. They present much like vitamin D deficiency rickets. Recently described are defects, and these are quite rare, defects in the synthesis of 25 due to mutations in the CYP2R1 hepatic hydroxylase that puts that 25 hydroxylase in place. And very recently, there's been specific point mutations in CYP3A4, which is an activating mutation and is responsible for getting rid of or catabolizing 25-hydroxy-D in a more rapid fashion, thereby depleting the stores of 25-OHD more rapidly. All of these present like vitamin D deficiency rickets and often have family histories that go along with them. Finally, 125 can not act, and some of these cases don't respond to any 125 vitamin D. Some respond to extremely high doses. We have a patient now on something like 15 or 20 micrograms a day of calcitriol, also with a lot of calcium on board, and she's finally beginning to heal her rickets with these very high doses of calcitriol. So all of those are the inherited forms of calciopenic rickets. Important slides for you to know are that these are the age-related calcium requirements for children. They're from the Institute of Medicine. And similarly, the vitamin D by age recommendations. So then there are the phosphopenic rickets, and I'm going to very rapidly go through these just to tell you that the primary forms are these are the transport defects, and we kind of break them down into what we used to call those that look like X-linked hypophosphatemia and those that didn't. And we now know that the X-linked hypophosphatemia types are due to the overactivity or overproduction of FGF23. Phosphate is regulated much like calcium, only the major place of total body homeostasis regulation is at the level of the kidney, and it's PTH and FGF23 that both enhance phosphate excretion. So a second case is that of an 18-month-old Dominican girl who had bowing when she came into clinic. Parents said it had been around for about 6 months. She had a classic history, and we thought she'd probably be vitamin D deficient. She was breastfed for 5 months. She was never given supplements. She avoided sunlight in the summer. She was of a pigmented background, which inhibits the UV absorption, thus creating some of a risk for vitamin D deficiency. She had a remote history of a cousin with transient bowing, but nothing else in the family history. She was short. She had a waddling gait, pretty severe bowing, and classic radiographic changes. Her biochemistries were of interest in that the major things going on were her very low serum phosphorus, a lowish 125D for the low serum phosphorus, and her alk phos was, although elevated for our lab, not that elevated. And this PTH was borderline elevated in our in the assay we used at that time. We looked at her urine, and it was clear that she had a very low urinary threshold for urine for phosphate excretion, and thus this put her into the category of X-linked hypophosphatemia, although there was no family history, and subsequently we learned that she does have a de novo mutation in FEX. So we've classically treated XLH as a replacement disorder. We think of it as in the normal situation, the kidney is making 125, it's retaining enough phosphorus to mineralize the skeleton. In this condition, you excrete phosphate to the point that you have limited availability to the skeleton. And if you replace it with phosphate and calcitriol, you can get some healing of the skeleton, but at the cost to the kidney of a lot of mineral throughput, and almost all of these patients get nephrocalcinosis, and it doesn't completely do the job. And then there's the recognition that this mutation that causes this disorder, found in the 1990s, and we still don't know physiologically what this protein is doing, mediates the phosphate loss by telling the osteocyte to make too much FGF23. And all the machinery to explain a lot of this disorder is in the renal tubular cell, where the enzymes to make vitamin D are present, and the phosphate transporters that allow for reclamation of luminal phosphate back into the body are present. And when FGF23 recognizes its receptor, which is also on these cells, and its co-receptor, which is required for this interaction called clotho, a mechanism is set into place by which the transporters come off the cell, and you actually make less of the transporters, you synthesize less of them, and you reduce the production of 125, and you enhance its you enhance the catabolism of 25D to 2425, all by applying FGF23 to that cell. So the strategy that we've been involved with has been inhibiting that interaction using an antibody to FGF23, and studies that we've now carried out this population for roughly 3 years are shown here, and this being the data up to 64 weeks were those that got the drug approved. You can see children were randomized to receiving this drug every 4 weeks, and their phosphate levels they got up there, but they bounced up and down. Even their trough levels were higher than baseline. But if you gave the drug every 2 weeks, shown in blue, you got a pretty steady state elevation in serum phosphorus, and that's persisted now out for over 3 years. Alkaline phosphatases came down. These are scores of their lower limb deformities over time. And you can see that in the 2-week group and in the 4-week group, combining everything, even at 3 years out, there's continued improvement in their lower limb deformity. I think some of this, the rickets can heal pretty fast, but I think the remodeling of the bow takes a long time. And I think it's taken 3 years in some of these patients to see the significant change in their deformity. Patient-reported outcomes have been better in this situation too. We'll focus on the right panel, which shows over time the increase in global well-being, baseline in gray and the 3-year points out in purple. There's a lot of domains in these scales, but the things that drove it were pain and discomfort in sports and physical functioning, shown here. This stripe here is the average for the normal population, and one can see that many of these domains are hitting normal now at baseline being quite low. I'm going to end by just pointing out this is not just a childhood disorder. These people were used to be thought that you didn't have a growth plate after you finished growing, you didn't need to be treated, but the osteomalacia does persist. There's a significant disability in adults. And for the sake of time, I'm just going to show you how severe some of these symptoms can be. You can see extreme, severe, or moderate is the bulk of this slide for all kinds of pain, stiffness, and physical functioning parameters in adult life. And so there's a significant morbidity in adults, and they often need to be treated too. They tend to universally start calcifying their tendons and ligaments. They tend to all get osteoarthritis. You can see these pictures of this guy calcifying his quadriceps tendon here. His patella has actually fused to his femur. Osteophytes all over the place. So it's a very ugly disease. Here are the bridging osteophytes and another guy that leaves him in his 40s and 50s very rigid and with not much flexibility. There's a lot of FGF23 mediated hypophosphatemia. This is just a slide that lists the bulk of these that we know about. X-linked hypophosphatemia is certainly the most common of these. I'm, for the sake of time, going to stop with respect to case 3 and summarize, and basically tell you that bone is a safe place to live. It is mechanically strong. It allows for mobility. Its development and growth and remodeling are highly regulated. Rickets, my favorite disorder, comes in all shapes and sizes, but it's usually attributable to a paucity of calcium or phosphorus availability to the skeleton. A deficiency of calcium and or vitamin D can cause rickets and are interacting nutrients. Other calciopenic causes of rickets include defects in vitamin D metabolism and its action. Hypophosphatemia is most frequently due to renal phosphate losses, but other mechanisms should be considered, such as malabsorption. X-linked hypophosphatemia is the most common form of inherited rickets. It persists into adulthood with debilitating multi-system complications. And regulation at local sites of mineralization are critical to affect bone mineralization and to limit vascular calcification. So we now know that alkaline phosphatase and ENPP1 are important members of a pathway that regulate this process. Our team at Yale on the research side is shown here. My longtime collaborator in the adult endocrine section, Dr. Carl and Sonia, has been invaluable to this work, as well as a longtime study coordinator and new mother, Elizabeth O'Lear. Our clinical bone clinic, send your patients our way if you want, is staffed by a fantastic physical therapist, a great orthopedic collaborator, and our lead nurse on it, Mary Bronson. So with that, I will say thanks, and thank you, Dr. Drash, for your inspiration, and Dr. Kenny for your establishment of a fantastic section in Pittsburgh.